Call to order the Health Committee. I'd like to have Councilman Chris Soap give the invocation, please.
Heavenly Father, Lord, creator of all things, we just come before you this day, Lord. We just thank you for this beautiful day you created for us, Lord. And we just pray that you will continue to bless our nation, Lord, bless our lives, bless our families, Lord. We just pray that you will bless our hearts with love, peace, and joy, Lord, and just be with us as we come before you in this council to discuss the nation's needs. In Jesus' name, amen.
Next we have roll call. Please.
Brad Cobb.
Here.
Janelle Fulbright. Here. Jill Anglin.
Here.
Bill John Baker.
Here.
Jack Baker.
Here.
Harley Buzzard.
Here.
Julia Coates. Joe Crittenden.
Here.
Jody Fishinghawk. Here. Meredith Fraley. Don Garvin. Chuck Coskin Jr. Tommy Boy Jordan. Present. Curtis Snell.
Here.
Chris Soap.
Amen.
David Thornton. Carol Cowan Watt.
Next on the agenda is the approval of the August 17th minutes.
I move to be approved.
Second.
All those in favor?
Aye.
Any opposed? The minutes approved from August 17th. There is one housekeeping. I'd like to amend the agenda right after, I know Melissa Gower is not here, but right after where her report is in this in the Health Committee handout, I'd like to add Marge Burton. She's going to talk on HIPAA, and I believe we have a handout on that.
We move to amend the agenda?
Yes.
So moved.
So moved. Second. All those in favor?
Aye.
Any opposed? Passes. First report from Claremore Service Unit, Jim Cousin.
I'm not Jim Cousin. But for those of you who don't know me, I am Vicki Snell. I'm the hospital administrative officer. And Mr. Cousin is in training this week for our 2008 clinical objectives. So looks like we're the seconds giving a report this week. In your report, I've just noted some things that are going on in the service unit. Most important thing is, this is the closeout for our fiscal year. So September closes another year of spending, and looks like our service unit will be closing out in the black, which is expected of us. And some things that are going on that we're focusing on for October. The flu vaccine has been received for our service unit. Looks like no restrictions. And we will attempt our first drive-through immunization clinic for patients. So we're working with the Claremore Expo to use their parking lot, and we're going to try to immunize as many folks in our service unit that we can and offer it, because there's no restrictions this year like there were last year. So hopefully our Commissioned Officers Association is spearheading that, and we'll have more details on it next month when we come back to you. Let's see. Next Wednesday, we'll have our annual governing board meeting with our folks from the Oklahoma City office. We'll be focusing on what we've achieved for 07, and then also look at 08, what they want us to look at, what we plan to try to focus on, the clinical objectives, as well as performance improvement activities. And hopefully we'll resolve some issues that we've had pending at our service unit with our leadership members next week. Two things going on as far as upgrading equipment. We have installed our automated pharmacy program. It should be completed by the end of the month, and what the new system will provide, hopefully, is to decrease our pharmacy wait time. We have struggled, and hopefully with the automation, we will be able to dispense medications faster during the day, and that system was purchased with third-party money. Let's see. Recruitment, it's a big issue at our facility right now. As you see in your report, we have several positions that we're recruiting for along the physician side as well as the nursing side to get those services back up. we are seeing a decrease in our visits because of the availability of staff to see them. So we are really concentrating on advertising, putting out nationally, and we have attracted some folks by advertising in national magazines and journals. So hopefully we'll be getting some of those positions filled soon. On the line of CHS, Mr. Cousin wanted me to ask that if at all possible, all inquiries for contract health services, if you have someone who is calling you wanting to know about their referrals or anything, if you could route those calls directly to our case manager. Her name is Teresa Payne. Her number is 918-342-6468. Hopefully this will help expedite the calls, and because if you're by going through him, they're having to turn around and research anyway. So maybe this will help expedite the calls. Email, yes, Teresa Payne at ihs.gov. That's her email address. She's our nurse case manager, very capable of helping you. Is very involved with the physicians at the review committee on the referrals. So she should be able to troubleshoot those questions for you very easily. That's about all I have. Do you have any questions for me?
Thank you.
Okay.
Oh, wait.
Sorry.
Councilman. So,
What type of advertising are you doing? Is it just in the clinic, or is it in the local newspaper for the
Oh yeah,
immunizations?
we've gone to JAMA. That's the physicians' publications. Tulsa World. We're doing it nationally.
Okay.
Yeah, and we've been getting some good hits off of those as well. Anything else? Thank you.
thank you. Next, we have Ed McLemore from Hastings, which I don't believe you're Ed, but that's okay.
I'm Tony Potts. I'm the clinical applications coordinator at the hospital, and I brought back up today too Jason Lebb. He's our medical records administrator. Mr. McLemore is attending the same training as Mr. Cousin today, so we are also, I guess, what you call sloppy seconds. But we nonetheless are glad to be here. Hopefully you do have a copy of our report that was submitted. I don't really have too many details regarding the report other than about collections, which is on page 8. We're pretty proud of our collections as we've reached the top goal for ourselves at $31,276,000 now, and that number is as of yesterday. So the number that you're seeing there wasn't as current as the number I just gave you. I didn't get any details to report, so I have my nose in the electronic health record all day as the clinical applications coordinator, so that's about all I know about. If you have any questions, I'd be glad to try to answer or take them back to Mr. McLemore.
Who is your contact person for contract health?
Contract health would be Kathy Morgan.
And phone number?
I don't have that. We can get that to you though.
And her email?
I don't have that either because she, I think, would be under the Cherokee Nation.
She's a Cherokee Nation.
Right. I'm not sure what the...
So it's Kathy Morgan at Cherokee.
At Cherokee.
Cherokee.org.
This is Cherokee.org.
Councilor Soto.
Yes, I've got a question. Do you have the same pharmacy expediting software program as Clarity? Do you have that same software?
The RPMS? No, we do not have that. We do plan to have a drive-through food clinic though. You know that.
Any more questions? Thank you. Next report, we have, and I know Melissa's not here, we have Melissa Gower from Cherokee Nation Health Services. And I think Dr. Graham's going to handle that.
Now, I'm proud to say Melissa is not in training. She is we've been asked to be involved on a state committee looking at universal health care for the state of Oklahoma, looking at uninsured patients in Oklahoma. So she is off in Oklahoma City doing that today. So we're excited to be involved in that and hopefully help come up with a solution for many people. For past council members, you see we have done our monthly report a little bit different this time, has a little bit different look to it. We'll get it to you sooner next time. This was our first stab at it. We'll be open to suggestions if there's things in it you don't like or different things you would like to see reported or things reported in a different manner. Let us know and we will modify our report. But this is our first stab at it. The big things, I'll be quick with, we have a couple of presentations we want to give today. We got the Access to Recovery grant, which is a grant from SAMHSA. That is our big, huge news this month. It's a $10.2 million grant that will be awarded over a 3-year period. And if you look at the budget breakdown, you can see the majority of that is actually going to go to direct patient care. There's a very small administrative portion with that. So we're going to be able to actually serve a lot more patients as far as substance abuse treatment goes. So that should address a lot of our issues that we've had in the past as far as making sure everybody that needs to be taken care of is treated. Program highlights, again, 26,726 patients served. We're adding at least 500 new charts a month and have been doing that for a long period of time. Hopefully, as Muskogee opens, we'll be able to accommodate more and more patients in a more timely fashion. Dental services, we're really excited there. We have added some Dentrix imaging software. We're going to use all dental digital equipment there, which will help us speed up our services that we provide and be more efficient in our services we provide. I'm assuming everybody's read this, so I'm just going to skim over and hit the big highlights. Contract health, we had 2,700 referrals in the month of August, and of those, we approved 92% at a cost of almost $1 million, and we only denied 227 of those referrals. So we've been able to do a lot more over the last several years than we ever have before. Other big highlights is everybody asks when will know what in Muskogee be done. Muskogee, have you been recently? A few days ago. It's looking much more like a clinic. Had a few minor setbacks with the weather until we got all closed in. And that was early in the summer. We've modified the flooring there now. I don't know if you saw the flooring we had in, but we've ripped it up and got new flooring coming in. But we're still looking, mid-October to be ready to open and start seeing patients there. And very similar situation in Nowata. We hope mid-October to have that building ready to go. So things are definitely nearing completion in those two facilities. If you look under the policy update, I'm very pleased to say, nobody else is, my husband will be moving home this month. So Melissa said I will be the only person happy about that, but that's okay. He asked the president to withdraw his name for a 4-year term as the director of the IHS, and despite all the speculation, he is coming home for personal reasons to be with his wife and his children. And I'll cry if I talk about it, but so all the other speculation is false. He is just coming home to be with us. Now I've lost my train of thought. And I usually don't cry in health committee. I'm usually not like this. That's our big things that are going on, and if you can just take a look back, I know everybody's had a chance to look at this, and if you look at our staffing, we're doing very well on staffing and recruitment, Chris. That's been something that we've prided ourselves on, and we only have 3 provider vacancies at the time, so we've been very active in recruiting.
We're going to wait till the end. Gotcha.
And we've included a list of our recent providers that we have hired. Again, I know the other big issue that has been on everybody's mind is revenue. If you look at the last page, you'll see that our projected revenue this year is going to be right at $15 million, which is almost a $2 million increase from last year. So our billing personnel has just continued to improve, and that starts at every level in our organization. Providers are coding better, data entry is doing better data entry, billers are doing a better job, so we're very happy with our third-party collections. And that is all I have. Do they have any questions?
Councilor Calvin Watts.
Thank you, Mr. Kelly. It starts October 1st on the referrals voucher program under that grant. So they just need to go to a behavioral health clinic or office or Cherokee Nation in order to get that referral.
That's correct, and we're working out, we just got it, so we're working out all of the details, but yes, and one of the bigger things is that, because we won't be able to provide all the services in-house, and the idea is to be able to provide them externally, so we've got to make sure that we do have contracts in place, but that everybody's geared up and can handle an increased volume of patients that we send them.
I know from my area there's a disconnect between the 5 and what we provide. And so will there be some kind of news release at the time to make sure that the community members, family members can outreach and help them get to the right place?
There will be, and we'll have outreach workers also that will help us.
Okay.
And we'll make sure that everybody in the community is aware.
Thank you.
You're welcome.
Councilor Soap.
Yeah, I've got a question, actually 2 questions. One about the medical services. It indicates in the report that there's a list of, diagnosis. Top 5 reasons for patient visits, and depression is within the top 5. Can you?
Depression has routinely been in our top 5 or top 10 diagnoses, and a lot of that is because of the association with chronic diseases. People who have a chronic disease tend to...
So that's in addition to these other...
Right. So, for example, people that have diabetes tend to have higher rates of depression, and we have such high rates of diabetes, and you have people that have higher rates of depression. And then you can talk about, and you can speculate on other reasons why, and as far as if you look at our family entities, they're not as intact as they once were. Socioeconomic status is a little bit lower. All those kinds of things tend to lead to higher rates of depression.
And then the other was, we talked a little bit about staffing. Had a citizen report concern over turnover rates at the Salina Clinic. Is that something you can check into and
that is
feedback?
And I can give you a little bit now. Some of it we'll have to talk about in a more private setting, but there have been several. It's been administrative positions that have left, very valuable administrative positions, medical records, people who do registration. It hasn't been our providers, but it's been other very, very valuable people who have been long-term there. And so we have talked to them, and we're trying to have them provide us information if there is a problem that we need to address.
There is a little concern in the community, just to let you know.
Okay.
Councilor Fulbright.
Down at the Redbird Clinic, we have the same concern he has. We seem to be having a lot of people leaving, and people complain that they can't see the same doctor. They're leaving, they're going here and there, and it's kind of like a bad patient-doctor relationship. Every time they go in, they see somebody new. And I was wondering about that, and also how many dentists do we have down there?
Okay. You're right. Your situation is a little bit different because with yours, it's medical providers. Part of the reason some of the people are leaving there, Dr. Moss, who's our medical director there, is going to transfer to Muskogee. He and his wife had relocated to Broken Arrow, and he asked to do that. What we've done, we've got 2 new providers coming on. One will be starting on Monday. She's very good. She's an internist. And then Mike Wiley, who used to work for us in the past, is going to be coming back full-time. And so those 2 physicians will be starting back. And that will still leave us with one provider vacancy there that we're trying to actively recruit. The people who have left there, one was Dr. Aldridge, who was very, very good, and we hated to see him leave, but we tried very hard to retain him. He found another opportunity that was shorter work where he paid more money and those kinds of things. But I think that now that we're going to be back fully staffed with those issues, people will be assigned. We're going to actually assign people providers. They give them an option of choosing who they want to be. I should say assign. They get to choose who a provider is. So they will be able to see the same person every time they go in.
One more question. I really don't know. This is just people telling me and calling me and complaining, but is the Redbird Clinic the only one that has all the appointments are same day, like where everybody calls in at 7:30 in the morning, or is the rest of them, are they doing the same thing? Or
and with Redbird, you can still get, once you're in the system, you can actually you can have an appointment 3 months in advance. But
I know that, but my concern is all these people calling me saying, I start calling at 7:30 in the morning and I can't ever get in, and I tell them, well, they've got a lot of people leaving, they've got a shortage, but that doesn't solve them when they've got to pull muscle, you know.
Yeah, no, and they can still walk in. I mean, they can still come in and be seen, and often they're able to be worked in. What we're doing at Salina, which is the model we want to try to replicate at all the clinics, we're only doing it with one provider right now, is we're going to have a team, and so on that team will be a physician, a nurse practitioner, then they'll have their own nurses and their own registration clerk, and so then I would call, so I'm assigned to the red team, which would be like Dr. Gray and Heather Zimmerman, and I'd call and say, I've got this. The nurse may be able to talk to the physician and say, well, this is all you need to do, or they may say, well, come in at 2 o'clock, he wants to see you. So we're trying to change our whole model of healthcare, which is a slow process, but I think it's going to work really well at Salina. Redbird Smith right now, I mean, a huge amount of the problem is we're just so understaffed there. But now that we're going to 2 new positions, I think that should really...
How many dentists do we have?
We have 2. We have 2 dentists.
Are there any more questions? Madam Speaker.
Do you have a timeline, is Melissa here, timeline on the dental clinic at Salina?
Oh, you're trying to put me under the gun today, aren't you? That is our next priority, and what we hope to do, the one thing that's honestly holding us back, I mean, it's on, I don't know if Todd's been in yet to speak, but it is on our, we have a priority list of new facility construction, and that's on the priority list. What we're doing right now is we're still negotiating with IHS the final amount of money that we're going to get with this for Muskogee, and once we get that amount of money, that frees up the current money we're spending at Muskogee to be able to operate dental, to do what we need to do there. So that is, I promise, our very next priority.
Because I know Jay is just overloaded in their dental.
They are.
It'll help
So
tremendously.
it would.
Thank you.
You're welcome.
Councilor Fulbright.
Well, I don't know if you're the correct person to ask this question to or not, but in overviewing this last year's budget, I noticed that there's been quite a bit of money approved for dental services, different things, medical, and it was not used, and everybody I see needs dentures or eyeglasses, and the way I read it, it was like it was turned back into the general budget. There's no carryover. And my question is, if I read that correctly, why wasn't that money used? Because so many people need dentures and eyeglasses, and they all tell me they can't get it.
We've used all of our money We
So I misread the report.
We always use all of our money for dentures and eyeglasses, and that's why we've been given additional money periodically to help supplement when we run out.
That's not what it said in the book. I mean, because several of us looked at it.
This is for dentures and eyeglasses specifically. We make sure we spend all that money, and we have. We try to be very judicious in making sure that it lasts throughout the 12 months. And
Sorry.
go ahead.
No, you're fine, go ahead.
What's the possibility of us getting mammogram services down at Redbird? Everybody has to go to Binge Clinic. That's something we really need down there.
That's something we're looking at, and one of the reasons that we haven't gotten that yet is we're waiting on. We keep thinking there's going to be digital mammography, which there is now, but it's very expensive. It's about $450,000 for a unit, and we expect those to go down in price. And so then we'd like to be able to provide that service there. Now we have a mobile that comes, but only comes once or twice a month, which doesn't cover the majority of the people. I mean, you can only get 40 people a day max on a mobile.
Any more questions? Councilor Jordan?
Dr. Gloria, if I'm reading our proposed budget right, there's no money for OA in your budget for dentures and eyeglasses. Am I understanding you do want some money?
We have money. We have money. We have, I think you all put in $500,000 and then another $250,000. Is that correct? I think we have $750,000.
For OA?
For 08. Do you remember, Bill John? I think you may have been the one that...
It was for 07, but 08, there's none proposed.
I thought we had money in 08. Kara?
Wait, Councilor Buzzard, you're next.
Yes, Dr. Grimm, can you furnish some stats on requests for MRIs, what's being paid for and what's been denied, and break those down by clinic locations? I'd like to look at those.
I can't. Here's where the problem comes in, is if they don't fall in our jurisdiction. So, because we cover outpatient, but it's only for certain counties. So some of those end up going to Claremore.
Okay.
And so...
And you wouldn't be able to get those?
Well, we won't have the stats for those. We can give you the stats for ones that fall within our contract health jurisdiction, which is not the same as our tribal jurisdiction.
You wouldn't be able to see those out of Claremore? Could you get the Claremore or Hastings?
Well, Hastings we have. We do those.
That's fine. Okay.
We do those.
Claremore you wouldn't.
I bet Vicki may be able to.
Should be able to pull something on our
They should be able to pull us. We can give you.
I'd like to see the stats on that.
We can give you those.
Okay. Thank you.
They can get Claremore can get you the ones they have.
Okay.
Councilor Cowan Watts.
Thank you, Mr. Chair. Dr. Green?
Yes, ma'am.
I think, first of all, I guess to address some of the questions, and I don't have my budget books out, but I believe it's in your regular budget, there is money for those.
Yes.
So, Eve, do we have unmet need from the folks who apply? Do we have unmet need in those areas, such as eyeglasses and dentures and stuff?
As of this point, I don't think that we do. I think that we're being able to serve everybody that comes and
is qualified.
And qualifies.
Okay, thank you. Then that answers that.
Councilor Fulbright.
Dr. Grimm, last month, Melissa gave us an update for the benefit of me and Mr. Thornton about contract health services possibly at Fort Smith, and she told us at that time that she thought the deal had been done for Sparks Hospital. We'd never heard anything else, and we were also wondering about individual doctors. Like if now we go to Redbird and someone needs to see a dermatologist, they send them to a specific dermatologist in Tulsa.
Right.
Is anything being done where we could go to a specific doctor in Fort Smith?
We were in Thursday and Friday, we were in Fort Smith and at a meeting, and somebody came in and told us on Friday that our contract had been signed with Sparks. And what we're trying to do with Sparks for the physician side, for example, at Hillcrest, we don't contract with all these individual doctors. We contract with Hillcrest. They call it Hillcrest Physician something group. And so that's the same concept we want to use at Fort Smith, is we contract with the whole medical staff, and they all agree to this one contract. So yes, the contract was signed Friday.
Well, are there any negotiation going on with the St. Edward since it's the premier place?
We have talked to them. We haven't gotten very far with them. So, to be honest, I mean, we'd like to get further with them. Sparks right now is much more willing and has been much more open to partnering with us.
That's probably because they've lost a lot of their customer base.
Yeah, I've read some things in the paper that haven't been great about them. So,
well, we would really like to be able to, for our people, Adair County the same way, according, they want to go down there too.
Yeah.
And it's just something we really need.
And we'd like to see that, because, I mean, not just from there's two sides to it. I mean, one you can do just the compassion side. I mean, I wouldn't want to drive an hour and a half every day to take somebody to get, radiation. And that's the compassion side. But from a business standpoint, it's much more cost effective, because otherwise we end up, people need money for gas, which we have to, try to provide those kinds of services. So from an economic standpoint too, it's much better. Even if you have not an ounce of compassion in you, you can look at it from a business standpoint, but it's a good thing to do. So we want those things to happen too.
In the interest of time, I have two more counselors to recognize, and I'll cut the questions off with that. Councilor Fishingham?
I just had a clarification on a question Janelle asked about this ginger program.
Mm-hmm.
Are you saying you have enough money that you're not requesting none this year?
We think we have enough money for next year.
Okay, so in 208 you have enough money, that way you won't have to come back and ask.
Now remember the word think. We think. But yes, we do.
Okay, thank you.
Councilor Thorne?
On the dentures and eyeglasses, I've heard this for 8 years. And every year we have to come back and put funding in there. And I'm glad that we've got the funding, because it generally comes from CME.
Right.
Or discretionary funding of some type. And I think that you probably will be coming back and you'll be asking, because I hate to go down to that clinic and see a sign that says no funding for eyeglasses. And I've seen it several times, and it's about every year that I see it. But I'll get off that subject. But now on the Sparks deal, it's through the grapevine and rumors that's going out there that will probably come about October 1. And I was wondering if there's any kind of date that you all have set.
It's October 1, new fiscal year.
Well, people know a lot, don't they?
A lot of the rumors you hear, there's always a little bit of truth in it, so yeah.
But that's all I had. Thank you.
Thank you. Thank you.
Okay, I'm going to go ahead and introduce Marge Burton, and we'll try to keep it short. I know everybody's hungry. Asked her to come today to talk a little bit about HIPAA. We have a new council, and sometimes when we don't answer things in here in a public situation regarding specific patients, we just want you to know why and understand. So, Marge?
Mrs. Burton, before you start, I wanted to interject a comment. I think those of us in the healthcare industry take this for granted, and I've thought about how to introduce this. I'm glad most of the counselors are here. Not only is it not proper etiquette to publicly mention a patient's name, it's actually against HIPAA regulations. And we need to really remember that as a council. And so I know you're going to touch on that, and I'm glad you're here.
My name is Marge Burton. I'm Manager of Privacy and Compliance for Cherokee Nation Health. How we operate, I'll just give you a little overview, since some of you are new counselors, of how we operate. We have what's called a compliance committee that meets, and there are representatives from each discipline for example, from nursing, from radiology, from pharmacy on that committee. But it also has representatives from other people with other departments within the nation that need to have access to patient information. So that includes child care, that includes ICW, all of those, and the IS people. And this is what's called a hybrid entity, and that keeps us, that allows us, the chief in 2003 did an executive order that allowed us to incorporate this committee, and that way we can share information that needs to be shared among other parts other than just within health. And so there are representatives of those on that committee, and that helps us to make sure that what we're doing meets the needs of all of the people. We do have, we give out in our clinics what's called a Notice of Information Practices. It's a little brochure, and it tells the patient what they can expect as far as privacy, what our responsibilities are, and what their rights are. And so those are available to every patient, is given that when they first come in, and they're available to the general public also. Then on an annual basis, we do training for everybody who is involved in what we call the hybrid entity. So all of us, not only do all of the health people receive HIPAA training, but also the ICW workers and the child care workers and all of those who get information from us. I view my job as being, I'm supposed to keep us all out of jail and keep us from getting any fines. And so that, if I'm able to do that, I feel like I've been successful. I gave you a publication from the Office of Civil Rights that gives a pretty thorough overview of HIPAA. So you can look at that and as much as or as little as you want. And what I'm going to try and do is just put into a nutshell for you what affects the council. That is that we must have a written authorization from the patient in order to disclose any information about that patient except for treatment, payment, and operations. Well, the council doesn't fall within that. Obviously, you're not involved in the direct patient care. You're not involved in actually paying the claims, like, for example, accounting would be. And healthcare operations has a very limited definition, and the governing board does not fall, this council does not fall within that. So it's kind of an unequal status that you have, because when a patient calls you and gives you information, that information is not collected within the treatment. And so you are able to then call health and discuss that information about that patient. Obviously, being a counselor, you're going to take care not to disclose that to anyone, but that's because that is not covered by HIPAA. But you can give us information. But in order for health to give information back to a counselor on any issue that you might inquire on, you would have to have a written authorization from the patient. In the past, the council has felt like this was an advantage to them because it kind of allowed them not to be quite so involved in an individual's care, and therefore not quite as responsible as if that patient called you and said, well, I really think that my contract health should be approved. And then you would be responsible for saying, no, I don't think it would be. So the response that you will ordinarily get from health is that the situation was reviewed and here are the rules that applied, or here is the standard of care that would, these are the policies that were applied in this issue. But we typically won't tell you that someone was denied for some specific reason. Does that make sense to everyone? Mm-hmm. So, do you have any questions?
Councilor Soap?
Yeah, just, what, you kind of went over and reviewed that, but what recommendations would you make when we get into those situations? Is it the personal information that they divulge it to us, then, are we at risk if we turn it back around and send an email to someone, or if we get on the phone and talk to someone about specifics, are we at risk then, or?
Okay, who is the someone that you want?
Let's say a patient calls up and talks about their diagnosis and then the X, Y, and Z, the results of that, and then say we need assistance with such and such. We're talking about people's names. We're talking about their conditions and so forth. Or,
you did not.
Like Dr. Morton was saying, if the grandmas and the mom and dad start getting involved and all this kind of stuff, what advice would you offer to me personally at this point? As far as what should we communicate in official documents, etc.
Okay. When the patient calls you, that information that they give to you is not protected. Mm-hmm. It is not covered under HIPAA. So you're obviously going to call probably Melissa mm-hmm. or Dr. Grimm, and so you can give all of that information to them. There's no
So the protection comes on the feedback side.
Right.
That we should just be in understanding that why you just can't have an open book policy is because there's limitations to that.
That's absolutely correct.
Any more questions? Thank you.
Thank you.
Next on the agenda is old business. I see there's none. And we have new business, Community Anti-Drug Network. Misty Boyd.
Good afternoon now.
Good afternoon.
I will try to keep this as short and sweet as possible.
I'm not getting blinded here.
Because I know that it is almost lunchtime. I appreciate the opportunity to speak. What I'd like to talk to you guys about, I'm involved through Cherokee Nation Behavioral Health in what we're calling the Community Anti-Drug Network. And that is part of a SAMHSA grant to develop what they call a strategic prevention framework. But it's a way to get out in communities and mobilize communities to combat substance abuse and related problems at the ground level, at the grassroots level in the community. As part of that, we're focusing on making sure communities have the right information to do things that will be useful and productive. Sometimes with substance abuse, we find that it's such an emotional issue and such a difficult issue with a lot of problems that it's easy to do what makes us feel good and think that we're helping, and we don't always know if we're helping. So we want to really study this and figure out what the problems really are, not just what makes the newspaper, and what really helps when communities go out and do those things. As part of that, we're doing what we call epidemiology work. So we're really trying to look at the population at hand and the patterns of substance use, and particularly how they use those substances and how that use is related to the consequences of using the substance. It'll make more sense as we go through the presentation. But this is part of the process that's mandated for us as part of the grant. It makes a lot of sense, and it's very appropriate for our communities and for our population. You'll notice it's a very circular process where we go through making sure we have the right information, making sure people have resources and tools and skills, and evaluating how we're doing so that we can go back and continue doing that over and over and over again until hopefully one day we don't have problems anymore. Okay, I'm going to put up here a figure of Oklahoma causes of death, just to highlight how important it is to look at the consequences of substance abuse in any population. In Oklahoma, the top 10 causes of death for the years between 2002 and 2004 included heart disease, cancer, stroke, COPD, unintentional injury, diabetes, influenza or pneumonia, Alzheimer's, nephritis, and suicide. Of those top 10 causes of death, some of our healthcare folks can tell you, and some of you may know from personal experience or experience in your communities, that most of those have some link to substance abuse. If they may not be caused by substance abuse, but they can certainly be worsened by substance abuse. So just to point out the importance of this isn't just because people don't go to work. This is life or death. Okay. I just want to put into context some of what we're looking at. In epidemiology, a very important factor is choosing the population that you want to look at. And honestly, we don't have a lot of good ways to do that right now. Our most comprehensive data source is the census data to give us some context for our area. I will tell you that that's controversial to use that data. It may not truly be representative of Cherokee citizens in this area, but let's just take a look at some of the things that it can tell us. Okay, if you look at American Indian, Alaska Native population percentages in the United States, American Indian and Alaska Natives don't make up a whole lot of the total population. In Oklahoma, that number jumps up to around 8% of the total population. In our 14-county area, we jump up even farther to about 10.5%. Now, I'm guessing this isn't news to anybody sitting here that we have a lot of American Indians living in our area, right? Another way to look at that is to look at it in this pie chart, to look at who else is living around in the same area. If the United States is your target population, again, you can see that American Indian, Alaska Native makes up a very small amount of that population. And then we have white, black, African American, and Hispanic Latino. Just to point out, an initial problem with this census data is that nowhere in there do we have figures on the percent of the population that is of Asian descent. See if I can get this to turn. There we go. In Oklahoma, again, you see how percentages shift so that there's a much larger percentage of the population that is American Indian or Alaska Native as classified by the U.S. Census. In our 14 counties, you see again, that purple is growing each time. So it's important to see what our target population looks like because our numbers change. The way that we see the data changes as we narrow down who we're looking at. Okay, and some context here. Median household income. Again, this probably isn't news to anyone. In the United States, the median household income is around $41,000, $42,000 per year. In Oklahoma, it's quite a bit lower, down to $33,400 per year. And in our 14-county area, around $32,000, $33,000 a year. So we're already seeing how in our area we have differences in who's living there and we have differences in the resources that are available to them versus the United States and even the state. Let's break that down a little bit more. This is the percent of the population below poverty level. On the first three bars on the left are the United States at 12%, Oklahoma at 14.2%, and our 14-county area at 13%. So if you look at those overall numbers, it looks like Cherokee Nation is keeping track with the United States. Those aren't numbers anyone would like to see, but at least we aren't worse off. However, if you go to a county-by-county breakdown, you see big differences. You see that percent of population below poverty level change tremendously. Anywhere from 22.7% of the population below poverty level in Adair County down to 8.5% of the population below poverty level in Rogers County. Okay. As a part of looking at the epidemiology data, we would like to know what kind of substance abuse is going on and what some of the effects are of that substance use. And we have several national data systems available to us. These are the gold standards. Unfortunately, when I break these down and work with my staff to break these down, we see that of those data sets, most of them are problematic for us. They really aren't very usable. A good example of this is mortality. Mortality comes from coroners and medical examiners' reports. In the state of Oklahoma, the way that deaths are recorded and put into this system are that the 5 largest counties in Oklahoma are counted as separate entities. So Oklahoma County, you can look and see the breakdown of what's killing people. Tulsa County, you can see the breakdown of what's killing people. Those most populated top 5 counties have their own, but every other county in Oklahoma is lumped together. So I can't tell you what's going on in our area or in any of our counties specifically. So this is a huge challenge that we're facing and working on trying to address gaps over the course of this project. Now I'd like to talk to you about consumption patterns and consequences for some of these substances, because this is really the heart of the matter and really what we want to know, right? Unfortunately, I can only tell you as far down as Oklahoma, and we don't know how different some of our areas in Cherokee Nation are. But if you look at patterns, that's the chart on the left. This is the percent of students who had at least 1 drink of alcohol during their lifetime in 2003 compared with 2005. The dark blue is U.S. numbers, and the turquoise is Oklahoma numbers. You can see that we really aren't that far different from the U.S., but one thing I would point out is that between 03 and 05, U.S. numbers declined slightly, and Oklahoma numbers increased some. So if you were just to look at that picture, you could see that there may be some kind of a trend there where youth alcohol consumption is increasing in Oklahoma but decreasing in the United States. Now, maybe that doesn't really mean anything. Maybe it's not big enough to mean anything. Or, for example, if we lived in a state with a predominantly, for example, Catholic population, that may not be surprising to see that a lot of youth had had their first drink when they were youth, because alcohol can be used during religious services. Now, if you're in a state where that's not so common, it might be more alarming to see those numbers. But what's really alarming to me is when you look at the consequences. So they had a drink, but look over on the right at the percent of students who drove a vehicle when they had been drinking alcohol during the past 30 days. So this wasn't asking, have you ever done it? This was asking, have you done this in the last 30 days? In Oklahoma, across males and females, a lot more of our youth drove a car after drinking alcohol in the last 30 days than youth in the United States did. So whereas we may not be that far off in how many take a drink during their lifetime, it looks like youth may be engaging in risky behaviors at a higher level than they are across the United States. Now let's look at adults. And I'm just pulling out some things that are really striking and stand out, and also give a good example of how you can look at the information differently. On the left, the chart with the jagged line is age 18 and older having 5 or more drinks on 1 or more occasions during the past 30 days. This is what we call binge drinking. You have a whole lot all at once. In the United States is that dark blue line at the top, and you can see that that percentage is a lot higher nationally than it has been in Oklahoma. However, if you look at the trend from 1990 to 2002, you see that the rate sort of declined in the United States, stayed steady for a long time, and sort of started rising again in the last couple of years. However, in Oklahoma, we see a lot more jagged ups and downs, and as you get to 98 to 2002, look at how sharply that rises, so that now Oklahoma is approaching the amount of binge drinking that we see nationally. So things are changing here. We don't know why, but we do see a change and a trend developing, and that's something that we want communities to know, to keep an eye on. When we talk about consequences of alcohol use by adults, then we have over on the right-hand side a chart with the percent of Oklahoma violent deaths testing positive for alcohol at the time of death in 2004 to 2005. Unfortunately, this violent death reporting system that this data is pulled from is defunct, and the state is no longer operating it, so we won't be able to watch that over time. But it is interesting to see that among suicides, more than 25% tested positive for alcohol at the time of death. Among homicides, almost 40%. For unintentional firearms, again, almost 40%. So you can see here that alcohol may be playing a role in violent deaths across the state. And I've got one more to show you. I know everyone's getting hungry, but this is consumption patterns for illicit drug use across Oklahoma and the United States. And when you ask for how many have ever tried this in their whole lifetime versus how many have ever used it in the past year, you get the figures that you see up there. If you just look at comparing Oklahoma to national averages, you see that we look like we kind of keep pace. We're just about similar to those national averages. However, this national survey of household health, which is where this data came from, has a lot of collection problems in terms of, for example, they just use random phone calls. So how many of your constituents don't have a phone and would never be reached by this? How many of your constituents won't answer the phone when it's an unknown number that comes up? How many of your constituents don't want to talk to somebody who asks them if they've ever tried cocaine? Right? So we can see there might be some huge problems with data collection here. And we're going to try to start with what we have, because this is all that we have available to us right now, and hopefully start building in some partnerships so that we can make the data more meaningful for our communities and the people who will be on the ground floor to do the work for substance abuse prevention. And that's the end.
Are there any questions? Thank you.
Thank you very much.
At the risk of being blinded here, we have one more item under new business. We need to set a meeting time for our next health committee meeting date. I believe is October the 16th. I would move that we set our health committee time at 10 a.m. and discussion.
We moved the education this morning to 1 o'clock for an hour and a half. Education is extremely important. Health is extremely important. And I was hoping that we could move health to right after that meeting at 2:30. And that way, if we ran a little long, it just be before we went home. And but you got a motion.
Well, we've got more discussion.
Would you be, Brad, would it be possible for us to consider going an hour and a half and maybe doing it in the afternoon from 2:30 to 4?
You talking about health? And I'd like some more discussion on this. I'm the extra 30 minutes. I think that, and I'll get to you in a second, I think that the point has been made by some of the incumbent counselors that I think after another month, that some of the questions will, I think there's a lot of questions right now because we got a lot of new counselors, quite honestly. So I'm not disagreeing, but I would question the need for an extra 30 minutes on health. Counselor.
Thank you. The point was made earlier also that if we have community services at 9 and then we don't have anything else until 1 o'clock, that we've got a big gap in there for 3 hours. And that being the case, that there isn't anything else, we could still have the health at 10 a.m. and go for an hour and a half. You know, there's time to do that if people wanted to do that.
Councilman Garber.
Thank you, Mr. Chair. I think 10 o'clock is the ideal time. Everybody's fresh, and it's just works in there at community services, and I strongly recommend 10 o'clock. I know other people are making big money doing other things, but Cherokee business should come first.
Councilor Coates, did you put that in the form of a motion, or that hour and a half, or was that a
No,
suggestion?
that was part of the discussion. I think Councilman Baker had brought that up, or Councilwoman Jordan.
Councilor Baker.
So we started at 10 o'clock. We go till we finish.
Yeah, we'll do our
So it would be a moot point. There's nothing. I would suggest that we go at 10 o'clock, leave it obviously, the way it's set now, and since there's nothing else, then we can, it's not like we have to, and if there's a problem, we can always come back and amend it. Any more discussion?
I move that we meet at 10 o'clock.
Second. It's already.
It's already on the floor. So what we're basically voting on is 10 a.m. Health Committee. All those in favor? Aye. Any opposed? I would move that we adjourn. All those in favor? Any opposed?